Hey, Section 3, here's the Week 5 wrap-up on hamstring, ACL, and cartilaginous problems. I thought you all got in there and did a really good job this week. The last 2 weeks have been a bit of a load with the workload and the weekend intensives. Thought I can tell everybody's working hard, and I appreciate that, and I appreciate everybody giving some good insights. A lot of people had some good insights this week. Obviously we have people who are experiencing some of these kinds of injuries and can speak directly to them. It was good that we had that opportunity to share. So we're going to quick go through the couple of the presentations in the literature. So a couple of things just to point out that I felt was really important in the Robertson article on management of articular cartilage. There's really no evidence for debridement. That's been going on for that. I mean, that information has been out there for a while. Hopefully that wasn't news to most of you, but can be a really good educational piece for your patients who perhaps may be thinking about this due to whatever their circumstances are. I still think cartilage repairs are dicey. There's not a lot of great research. The sample sizes are small. The procedures are kind of all over the map, in my opinion. I still, if I had an option to have to do this surgery, I'd be thinking long and hard about that. Lack of weight bearing, I think, is really challenging when these people, they go out 6 weeks and they're non-weight bearing. They're so weak. It takes them so much longer to get better. And if anything, this is for the young and not the old. Cartilage issues for the old over the age of 50. I just have seen far too many patients who have had knee scopes done and yet come back with the very same pain and not had physical therapy. The surgeon had just decided this is the best way to go and we're going to do this. Moving on to the Robertson presentation on non-operative ACL deficient knees. 90% are surgical repairs, but do they really need to be for the ACL? Copers versus non-copers doesn't predict surgical outcomes. That I found was very interesting. I always think that, you'd expect the copers to do a better job just because they have the ability, and you give them an ACL, they should be even better, but not necessarily the case. So he finishes up talking about, if you find a coper or you're trying to figure out what a coper is, that joint stability I think is really key. That joint stability says that they have an innate ability to use other systems to kind of stabilize themselves. He also talks about full knee mobility, but I have found that if they are going to be a coper, that ability to stabilize the knee is really critical. The Van Griesen article makes a great point that the most needed piece of literature that is an evidence-based model that returns people to sport in a safe and effective way. The Accelerate, people commented that the Accelerated program was new to some of them, and yet there were others who really were well on board with this and were practicing it as we speak. The key here is standardization. We as a profession can't deviate, have one group doing some 1985 protocol and another group doing a 2014 protocol. Everybody needs to be on the same page. Standardization is the key for the success of our profession, and it really knocks us down a peg when we can't all get on the same page. And so think about that moving forward, about a lot of the things that we do, whether it's low back pain or ACL repair. We all need to be on the same page. The Froebel article did appear to surprise a lot of folks. A lot of people were fairly surprised that ACL injuries could do as well as they could. And as a profession, we need to have better awareness of the available literature. We need everyone to be educating patients about their options. Surgeons have dominated this discussion for far too long, and we need to take a professional stand, helping educate the public and being aware of their options. That being said, we obviously need better tools to figure out who these people are and who they aren't. So as much as I like to point fingers at the surgeons, the finger gets pointed right back at us in a lot of cases. The Riddle article, everybody said that they were using some form of this in some way, and I think that's really good because that gives you confidence in sending a patient home and not having sent him to the ER. So having that CDR on DVTs, I think, is important next to your desk, especially if you treat a lot of post-ops. So the Hayterscheit, hopefully I said that right, article on hamstring injuries. Discussion on prevention, both for ACL and hamstrings. Do we do enough? That's really the question, and that was raised kind of in the different posts. The hamstring prevention program seems to be a much more promising. The eccentric loading seems to have a lot of legs, with stretching not being so much. But I would argue that, and even in the Hayterscheit article, they talk about don't forget to assess neuromobility. This often goes untested, so make sure you're slump sitting these patients. Return to sport needs to be much simpler. Even in this prevention program, the eccentric training stuff is really good, but if you look at what he writes for return to sport, it's very cumbersome. It needs to be simple, like the ACL progression. It needs to be triple hop, single hop, crossover, and you're done. not isometric, isokinetic, mobility, just like generalized mobility, strength. I mean, there was just too many factors. It needs to be nailed down. We need a better return to sport for hamstring. Thankfully, this isn't as big of a deal. It's not as, if you re-injure a hamstring, it's not like tearing your ACL again. Standout posts. So I'm highlighting more group discussions that I thought were really good this week. And Alpha, Josh, Matt, Joe, and Christina all have interesting discussion about treating work comp like athletes in their recovery. Love it. I think that's tremendous. That's how work comp should be treated. Breaking down different components. Sport, instead of sport-specific training, it's job-specific training. Treating work comp like athletes, I think, even helps the work comp patient understand what's happening. You can say you are in training to get back to your job. You have a physical job, and this is how we do this. And I believe it was Josh who was kind of breaking things down, and people were kind of chiming into what he liked to do. Pierre and Josh share a good discussion about COPR versus non-COPR, and as a profession, how we need to improve our overall education / approach. Right? Too many people think that they say tear their ACLs and they go to surgery. Too many PTs think they tear their ACL and they go to surgery, when in reality, that's not the truth. So, and Charlie, Pierre, and Jamie have an interesting discussion on slump technique in regard to hamstring strains versus sciatic nerve irritation. I think that if it's a chronic hamstring strain, you better be looking at their neuromobility, because if you're not, there's a problem. I think you're missing out on a key component to their collective rehabilitation. Delta. Laura and Megan had a great discussion on late early phase rehab and the number of visits. I thought this was very interesting. I agree. I believe it was Laura who said that, or it might have been Megan. I'm sorry, I apologize. Who said 3 times a week, the first couple of weeks is not necessarily necessary. I totally agree with that. I might go twice a week the first week, and then I'll go once a week, and this is now, granted, now there are certain patients that need more hand holding than others, but most people can, you tell them to keep their legs straight, you tell them to ice, and you do these couple of exercises, and you come back and see me in a week. By week 4, I'm typically more limited by time and waiting for the healing process to take place, and I am waiting to progress them through their rehab. So, I like accelerated phases. I think that they're right on. And if you think back to what they were doing in the 80s when they put people in casts and they have them non-weight bearing, and now we're doing close kinetic chain stuff as soon as we possibly can. I just think that we're seeing that this evolution take place as we become less fearful of re-injury. And then the late phase stuff, the number of visits, and then kind of post rehab. For me, and I said this, I kind of responded to their post. For me, there just needs to be more research to show where we can be beneficial or where we're failing in the rehab process that's causing re-tears before I'm really ready to get on board with that. Certainly there's sport-specific training that would require somebody to need perhaps some more hand-holding or some more guidance as far as progression. Whether insurance companies are going to pay for that, whether that's our role in a private insurance base, or if you're thinking from a collegiate standpoint as part of the team of rehab specialists, that would be a different story. But there's a lot of issues about that, and right now there's just not a lot of literature to support us pushing the time frame or the number of visits on that end out further. But in the end, it may be where we need to go. So week 6, looking forward, ankle foot disorders. This will be good stuff. We'll talk more about the eccentric training, tendon tissue healing. Group project objective is due on Monday. With that being said, if you go Tuesday, Wednesday, knowing that you're then not going to get your objective information until you give me the subjective, I guess depending on what is going on with your group, if there are people who are jammed this weekend and aren't going to be able to get that stuff done, you can push it out till Wednesday or Thursday if you need to. And I'll also be looking forward to the fellow case studies. Hope everything is going well with all of you guys. I appreciate your hard work, digging in, taking this all very seriously, and really putting out great effort. I wish you keep up that hard work, because we're starting to get toward the other end. You're starting to see the light at the end of the tunnel. And by after this 6th week, I think that you for sure will. So hope you all are well and take good care. And if you have any questions, obviously, give me a shout out.